Hello, everybody, and welcome to this webinar, Shaping the Future of Clinical Leadership and Innovation. Thank you very much for joining us today. This webinar is brought to you by the National CLEAR Programme and the Faculty of Medical Leadership and Management, who have been working in partnership now for some time and done some work on this particular issue around supporting leaders in making change and innovative change. And felt that it was a key topic to discuss further and bring out to discussion in the wider community. So my name is Matt Camilleri. I'm an anaesthetic trainee in the West Midlands, and I'm also the lead partnerships for the National CLEAR Programme. I'll be hosting the webinar today. Thank you for giving up this hour of your time. Please feel free to turn on your cameras if you wish. You may be having lunch, that's okay as well. I hope you enjoyed that music prior to starting. Suggestions for different tracks for next time, welcome in the chat or on a postcard. But we'll jump straight into it and we'll have a look at the agenda for today. The next slide, please, Namisha. Thank you. I just want to click through. So we'll be starting off with some key talks from two of our speakers who I'll introduce momentarily, looking specifically at the critical intersection of leadership and transformation skills, which we think is an increasingly important topic. Then we'll look at some work that we have done in partnership in a program called Leading Beyond Boundaries, and we've got some of the team here today to talk through that, and hopefully some participants joining us as well. And then we'll be having a panel discussion, so all the speakers will be back in to discuss the topic in general. And at that point, that's when we'd like to bring you as the audience in to discuss things and ask any questions. Feel free to put things in the chat throughout. We may not be able to get to them because of the tight time schedules, but what we will do is in the panel discussion, if you'd like to ask a question or be involved in the conversation, please put your hand up via the Teams function and we'll try and bring you in. So yeah, that's the next hour. And thank you, Namisha, today's speakers. So giving us some key thoughts initially. So Dr. John Jeans, consultant anaesthetist, he's CEO of the CLEAR Programme 33N. After that, from FMLM side, we've got Jasmine Begmal, who's a trustee of FMLM and a senior executive editor of The Lancet. And then also joining us from the Leading Beyond Boundaries delivery team, we've got Dr. Fernaz Sharif, who's a GP and executive leadership coach. We've got Claire Perkis and James Albright, who are both consultants as part of the National CLEAR Programme. And I've already introduced myself. We're also hopefully going to be joined by two of the participants today as well. So that's Dr. Nina Gerdes and Dr. Matteo Di Martino, who are both part of that Leading Beyond Boundaries programme. But without further ado, I will pass us on to John Jeans to start us with his first talk.
Thank you very much, Matt, and thank you very much, everyone, for joining today. I will just go through for the next 5 minutes a bit of a story about how I got into this kind of work, and as well as talking through, I think, the imperative that we all have to be part of the innovation ecosystem that exists within the NHS because of the impact it has, not just for our colleagues, but also for our patients. So if we can move on to the next slide, please. So a lot of people ask me why an anaesthetist would have an interest in innovation or workforce transformation, or indeed change outside the world of anaesthesia. And the reason that I got involved in this work is about 10 years ago, nearly 12 years ago now, my dad became a patient. And he ended up passing away. And his journey from his diagnosis through to his death was not the kind of journey that we would want any of our patients to have. For context, he had a slightly delayed diagnosis within primary care for a gastric cancer. When he was referred to secondary care, he had a choice to go to different surgeons within London. And at that time, if he'd gone to his local hospital with his local surgeon, he would have had a 15% 5-year survival from his gastric cancer. He was fortunate enough to be able to go to St Mary's Hospital, where there's a chap called Professor George Hanna, who does some really interesting work. in surgery for gastric cancer, and Prof. Hannah has a 50% or 50 5-year survival rate. And that change or that discrepancy in diagnosis is not the kind of survival rates is not the kind of thing that we want to have in our NHS. The other thing that I noticed is that throughout his care there was just bumps along the journey. So his operation got delayed for 3 weeks because each week there wasn't an ITU bed for him to have, because he obviously needed quite a big op for his gastrectomy for his Royal Y. Although he had a really good outcome from his surgery, 6 months later he ended up having a recurrence, and that recurrence basically meant that there was nothing anyone could do. It was a bad recurrence. The cancer came back, wrapped itself around the liver, and he was for palliation. But what was again so interesting is it was difficult to give him a good death. And although he ended up in hospital because he became jaundiced and became unwell, he wanted to die at home. So what we ended up doing was taking him home, but having to self-discharge him because there wasn't the facilities or the community care at home to look after him quickly. And we got him home, and although a referral had been made to the community team, which meant that we got a syringe driver, there was no meds and no one to help us sort of set up the syringe driver or look after him. So we ended up, my wife and I, another anaesthetist, getting the out-of-house GP to come to the house. They came to the house and wrote up a end-of-life meds. We took them off to the out-of-house pharmacy, came back with a whole bunch of vials of different end-of-life drugs, and we called up the hospice. And the hospice said, draw up these meds in these ways and call us back every 12 hours. And don't worry, someone's coming and everything will be okay. So we did, as they said, religiously over the next week. And a week after that conversation, my dad passed away. And 2 days after he passed away, the palliative care team came around to the community and said, is there anything we can do to help? And that experience changed me. I was obviously very upset. I was grief-stricken, and I was very much on the path to becoming a grumpy colleague, with the joke that I always say, not that everyone's ever met a grumpy anaesthetist, we don't exist as a profession, but I was on that path. And so what I ended up doing is taking some time out from clinical practice, got involved in, of all things, a workforce readers or modelling program, because I thought that the answer to improving health services was in the numbers. And if we just had access to numbers, that will enable us to improve the care that we delivered. And what I learned is that changing workforce or data is great, but it's what we do with that data and how we help people innovate and solutionize around that data. That's what matters. So I was very fortunate to have the opportunity about a couple of years later, after doing a couple of different projects using data to help people change clinical practice, to set up a program which was nationally commissioned by HE. And that program is the Clinically Led Workforce and Activity Redesign, which is a program that's trained hundreds of staff across the country and done a whole range of different projects across acute community and primary care to support people improving outcomes for patients. And as you can see on the slide, that's very helpfully changed over. It's a hosted program at East Lancs Hospitals Trust, and for the work that we're doing within BHRUT, done very much in partnership with FMLM, which is great. Can move on to the next slide, please. So I just want to sort of leave everyone here with some thoughts about how we all can take responsibility for improving the care that we give our patients, and do so in a way that embraces innovation, but also positive constructive behaviors, because I believe that through these levers, we can actually do a lot of good for our patients. And we all, as clinicians, own that, because we are the people that end up giving the care to our patients. Now, that's not to say it's just clinicians. Operational colleagues, administrative colleagues have a lot of contact with patients, and we can all have an impact in the work that we do. But in terms of clinical pathways and transforming clinical pathways, we do need, as clinicians, we do need to lead in this area because it's where we have our domain, our technical expertise. If we move on to the next slide, please. This is critical now. The NHS staff surveys says that 42% of staff are feeling worn out at the end of the day. That number has gone up over the years, and it's particularly profound since the experience that we all had with COVID. So more so than ever, we need to think about how we can innovate, how we can lead, and how we behave within our organisations so that we can support our staff and our patients to get the best possible outcomes. And this is critical now, ever more so than it has been over the previous decades, because resources are going to become more and more constrained. And within that constrained picture, the only thing that will enable us to continue to improve the care is the way that we innovate, the way that we lead. We'll move on to the next slide, please. Having said that, it's tricky. 50% of staff say they weren't involved in deciding on changes introduced to affect their area of work. I'm surprised that it's only 50%. I could imagine that people would often feel that it's higher. And innovation is tricky, and innovation does stall. And as you could probably see from my individual story, I had an event that changed the way I view the world after my dad's death. But it took about 6 years to get to the point where the CLEAR program could be created. And that journey over that 6 years led to me walking into lots of lampposts and learning loads from each mistake. And we're very fortunate that when we're in a space where we can innovate, that we can, if we do so in the right way, we can make mistakes and we can learn. And having that supportive culture, which we create for each other, is absolutely critical in enabling us to generate innovation, and also not being scared of mistakes, because we're going to make them all the time on the journey. If we move on to the next slide, please. So what we need is a new model of leadership. I think this is a great quote. The NHS is full of great people. What we need are systems and leadership to help them do great work. And we all need to lean in to the systems that exist and do so. And when the systems aren't what we need them to be, constructively engage with people who own those systems to help them be the systems we need them to be to improve the care that we give. And that is a constant evolution, not least because of the new technology that we have coming through with AI. But it's something that perseverance, hard work, and determination are needed so that we can build and sustain this new model of leadership. And that involves growing people, not just projects, which I think is very. So thank you for the slides, Amisha. It's perfectly following. That involves growing people and not just projects, and we all need to own that. So without further ado, I'll hand back to you, Matt. But thank you very much for the introduction today. And to conclude, we just need to do things a little bit differently, not the same.
All right. Thanks, John. We'll move straight on to Jess, but thank you for that insight into your personal experience as well. So Jess, over to you. Thank you.
My name's Jessamy Bagenal. I'm a senior executive editor at The Lancet, and I've just become a trustee for FMLM. I am an alumni. Can I say that word today? An alumni as well, in that I did this fellowship about 10 years ago now. And I'm filling in for Rich Withnall, who is the CEO of FMLM. And I'm sorry to be a very poor replacement, but I hope that we'll have 5 minutes today where we can briefly go over what the Faculty of Medical Leadership and Management do and why we feel that now is such a crucial time for clinical leadership to be expanded, nurtured, and improved. Next slide, please. So FMLM has been established since 2011, and it was established by Medical Royal Colleges. And it's a membership organisation and a charity. There's also a private arm which does some leadership courses. And we're essentially we're a home for clinical leadership. We're nurturing the next generation of clinical leaders. Next slide, please. We have lots of different outputs. Some of them are a sort of membership and designated bodies. We've got over 2,000 members, and over the last 10 or 11 years, we've had 350 fellows go through our program, which gives a year-long experience in an arm's length government body or in other institutions in health around the UK, and is an opportunity to promote and progress your own clinical leadership, and then go back to your base institutions and implement your learnings. We also develop professional and evidence-based standards. We do a leadership development program delivery, and we are hoping that one day we might be a college. Next slide, please. So this is the sort of brief structure of the Faculty of Medical Leadership and Management. We're small, we're very agile. And we look to improve a number of different outcomes, including improving leadership competence and confidence. We hope that this will always provide better value for money, improved equity of opportunities. When you look at the data on who is a clinical leader in the NHS, it's not a very diverse population. It's very homogenous, and that's about opportunities. And we also hope to improve healthcare sustainability. FMLM is a leading voice within the UK Health Alliance on climate change. We all know that on average, healthcare systems contribute about 5% of global greenhouse gases. And so if we're going to be able to advance a climate change agenda, then we need to be leading that ourselves. I can't see the presentation. Oh no, I'm sorry about that. Is there a problem with the slides? Can others see the presentation?
Yeah, I think most of the others
Yeah, I
can.
can see them.
We'll
Okay,
let
great.
them sign in back out. Yeah.
You can see it.
Okay, perfect. Thanks very much. And we really try to engage with leadership at every single level. So leadership of yourself, leadership of teams, leadership of organizations, and leadership of systems. Next slide, please. So why is this so important right now? Well, we're in an extremely complex time. The NHS is one of the world's biggest employers, as we all know. And as John mentioned earlier, the rate of sickness-related sick days or work-related sick days is extremely high, particularly for different professions like nurses and allied healthcare professionals. The fiscal climate is not a friendly one for healthcare. This is not 1997, where there's going to be a doubling of the NHS budget over the next 10 years. We're in a completely different fiscal time, and there are real implications for all of our work. And we have population growth and demographic changes. You know, these arguments are well rehearsed, but it's just worth reminding us where we are right now, which is an extremely difficult time in healthcare, not just in the UK, but globally. Next slide, please. And when you're in this type of position, we have mountains of evidence, ideal in evidence. We know really what we should be doing. But when you look at that implementation gap, that is enormous. And much of that implementation gap is about context and people at the ground being able to implement those things. And that's where clinical leadership from medical professionals, but also leadership across the board from anybody that's working in healthcare is so crucial. So we have this quadruple aim to improve the health of the population and health equity, to improve the use of resources, to improve the health and well-being of those who provide and support care, and to improve the experience and outcomes for patients and service users. Much like the personal story that we heard earlier, we see this on several different levels playing out over the NHS. And we do that through this expanded sort of circle of trying to improve our awareness and our ability of clinical leadership, all the way up to how that might impact at a societal level. And if you haven't checked out BMJ Leader, please do check out BMJ Leader. It's filled with very interesting articles. Next slide, please. So how we see differences being made. We've all been in the NHS, and often I think we feel that seniority goes with some kind of expertise in clinical leadership and management. You'll see that many people are handed over leadership roles in their senior years, and actually they've never had any training, and they've never been exposed to many different not only literature, but also courses and development. So we believe that leadership is a journey, it's not a destination, and we try and have an impact at every single level, not just at the very senior level, but also at the junior level. Because at each stage, there's a real possibility to improve patient care, to improve the ability of teams to function, and to improve the overall experience. Next slide, please. So this is our kind of how we view improvement and our different pillars and what we try to promote at FMLM. And I think that you'll see and hear later on from a deeper description of the CLEAR project that there are so many examples where implementing better clinical leadership results in better patient outcomes. It results in more cost-effective ways of doing things. It results in better staff well-being, retention. And we see that time and time again. And I loved reading about the CLEAR program, and I'm looking forward to hearing about it more in the coming presentations, because it's a great example of why this works so well. Next slide, please. I think I've done that in 5 minutes. I hope I have. So come on a journey with us. Please check out our website, see what we offer. Come and join us, because now is the time to really develop and promote your leadership in a clinical setting. Thanks so much, and I look forward to the discussion.
Thank you very much. Thank you very much for those insightful talks. Hopefully we've drilled down to the point that of this kind of critical intersection of leadership and transformation skills. And I think the pressures and the environment in which we're working in has been highlighted in terms of challenge. I've just got one quick question for both of you. So feel free to jump in with your own perspectives very briefly. I think we've highlighted there the challenges. How can we maintain impetus around training development, maintaining the leadership and active positive change through that, with all these pressures that have been mentioned, operational pressures, the kind of up and coming issues around personnel and financial cuts?
Jessamine, do you want to go first for that one, or shall I?
Yeah, sure. I think it's a really good question, and it's a difficult one because there's a tension between service delivery and between being able to develop these skills and implement these skills. And I think that's where we are at the moment. So many people that I talk to, I don't do patient-facing care anymore, but my husband still works clinically, and obviously I'm deeply involved in that ecosystem. And essentially everybody is firefighting. And when you're firefighting, it's very difficult to think strategically. One way is structured fellowship programs, as the Faculty of Medical Leadership and Management do. But really, we need this in every hospital, in every place, and that sort of focus. But I also think it comes from senior leaders being able to give people time to develop those types of skills and to be interested in being able to implement, to innovate, and to be agile. And to do that, we're going to need to adopt and embrace a whole load of technological changes. And we're also going to have a huge amount of support, push, and overall kind of funding from a government point of view.
Yeah, Jessamine, I completely agree. It's a very, very tricky one. I think going back to your last point about funding is that is proving tighter and tighter. That comment you made about we are not going to see a doubling of the NHS budget, which we did over the sort of 10 years from the late 90s to the late 2000s, that is definitely not going to be happening. And so to create the space to develop is actually even trickier than it has been before. I think to create that space, the sort of responsibility comes at all levels. So there's definitely a responsibility from senior leadership to advocate for these skills to be developed. But there's also a need, I find, or there's also a need for all of us who want to be involved in this kind of work to think about the impact that we can have. One of the things that I was just reflecting on my effectively in my list, just so I have a couple of regular operating lists, is that we're thinking about how to build or help develop colleagues in a sort of frontline clinical space to learn some of these skills. And we've been trying to do it within the work that is already being done. And you can do something in that space. Look at the data around your operating list, think about how you can make it more efficient, and have the conversations in a constructive manner. But what is clear is that if you can demonstrate or have a view as to the impact that you can have from further development, it becomes a lot easier for colleagues to give you that space. So the thing that I sort of come back to is when things are constrained, when there is firefighting, we have to be really focused on the positive impacts that we can have if we have new skills or if we have the support to develop others and to develop ourselves. So being really focused on the benefits gives people the opportunity to give you a path to improve. And that's, I guess, something that is just, I think, fundamental in the current constrained times.
Yes, great. Thank you both for your thoughts. We're going to move on now to the next section and hear about some practical implementation of that in the kind of case study Leading Beyond Boundaries. I'm going to hand over to Claire. I think we've been joined by Nina and Matteo, who are both there with you for when you want to bring them in, Claire. So I'll hand over to you. Thank you for the hands up in the audience, by the way. We will get to questions from you at the end. Thank you.
Perfect. Thanks very much, Matt. So as Matt said, my name is Claire Purkis. I'm a managing consultant as part of the CLEAR programme, and I've been the clinical lead for the CLEAR project side of the Leading Beyond Boundaries programme that we're running at BHRUT. So just to give a bit more kind of detail about the aims of the CLEAR programme. So we have multiple different offers as part of CLEAR, but all of them kind of have the same kind of underlying ethos as kind of John was alluding to at the start of the webinar today. So we're all about empowering clinicians with the main kind of focus to be improving patient outcomes, looking for efficiencies, but also really kind of in the spirit of collaboration, involving people that work in the services that the change is happening in every step of the journey, and really kind of empowering people to feel that they're having that voice and really owning the change. So you can see some kind of headlines on the side here. So very much a clinically led culture. So as I said, giving that control to clinicians and clinical teams, so very much working alongside of and with those clinical teams rather than coming in and doing things to a department or service. Along the way, hopefully embedding some of those new skills, and that's absolutely been at the heart of this Leading Beyond Boundaries programme. So this programme in particular has had a very strong teaching element in the first year, and what we're looking to do is build that sustainability, as we've just been talking about, so that we're working alongside of this core group of consultants at the Trust to build those skills, put them into practice in year 2, and then hopefully can kind of create that sustainable community of practice ongoing, where, you know, once we as CLEAR and FMLM have left, those skills are kind of continued to be used in other areas, in other transformation projects. So looking at new ways of working, that's the output of kind of all of our project work. So looking at more efficient solutions, supporting that complex change design, and coming up with sort of well thought out and well evidenced and well backed by data solutions and recommendations. And hopefully, again, those solutions are clinically owned, which means that they're far more likely to be implemented, again, once more, once we've gone and our kind of work in the Trust is finished. We'll move to the next slide, please. So all of our programmes, again, to some extent, in greater degrees of kind of depth, follow each of the 4 phases of a CLEAR project. So we start off with clinical engagement, so talking to a wide range of stakeholders, making sure that we're really seeking out those dissonant views, really understanding in a service what is working well, what isn't working as well, what are those challenges that come up day after day, where are the blocks, and that really helps to kind of get that buy-in from the department, but helps also then to focus for our next stage where we look at data, the quantitative data, What should we be looking at? What are we going at? What are our hypotheses about what isn't working? And what data do we need in order to kind of challenge those or kind of back that up? So like I say, we form our key kind of themes out of clinical engagement using a modified thematic analysis. We take that into quantitative data visualization, where we're using locally owned data, and that's often put into visualizations, which are then easy to interrogate. So the clinical teams get experience of kind of coming up initially with data requirements, but then also interrogating that. And like I say, at the end of that, we triangulate it. So you have a really kind of hopefully solid case of this is the challenge and this is the impact of that challenge and these are the numbers. We take those triangulated challenges into our third phase, which is innovation. In this, we encourage kind of blue sky thinking, thinking outside the box, anything goes. So starting off with all the wild ideas and then gradually refining those and working them up into a solid model of care. So a fully costed model of care, complete with impact as well. And that's then put into recommendations. So we'll put that in the format of a report, which will outline the kind of narrative of the journey. So how we've ended up at these recommendations, if they were to be implemented, what that would look like in terms of impact. And each step along the way of this journey, key stakeholders are involved at every single point. So again, none of this is landing as kind of fresh news at the end of a project. There's been that continual involvement from senior decision makers throughout the project. So we've been really lucky with this project to work very closely, if we go on to the next slide, with the FMLM. So this is our first co-delivered project. It's been absolutely fantastic because, as we talked about, there's such a huge intersection between leadership and innovation, and the two are so crucial to kind of sit together. As we know, anyone that's done any kind of improvement work knows that you need to have that leadership to keep the momentum going. You're going to hit blocks and you need to keep going and find those ways around and find those ways of bringing people in, bringing people on board, listening and hearing to what people are saying, but really trying to kind of gather that enthusiasm. This project has been really well supported as well by senior medical leadership at the Trust, so by both the site medical lead and the CMO, but also colleagues in HR, medical recruitment, in the innovation team. So again, we've had really good support and buy-in at that senior level as well. And the aims and objectives that we set out at the start of this 3-year programme were to support recruitment and retention at the Trust. So we wanted to make the Trust an attractive place to come and work, and to develop that system thinking approach among consultant colleagues and other professions. So again, that was very much behind the name Leading Beyond Boundaries for the programme. We wanted people to be thinking outside of the kind of siloed areas that people end up working in, really thinking about how they could collaborate and think at more system level. Developing those strong leadership and transformation skills through the education programme in year 1. And then in year 2, where we're just at now, putting those into practice through delivery of clinically led transformation projects. So we're just about 2 months into now 4 clinically led transformation projects across 4 different specialty areas at VHIT, which is really, really exciting to see those skills being put into practice now. And lastly, and I think this has been one of the really lovely things to see that's come out of that first year, is to develop that peer network across that consultant group from different specialties. And again, there's already been talk about how that group want to, again, create that almost community of practice, that mentoring, how they can pass on those skills to other people within the Trust as well that are kind of coming up behind them, which again has been really, really lovely to hear. If we go to the next slide. So this is just a very brief overview of how the programme has been set out. So it's across 3 years. So year 1 had a real focus on teaching. So there was initially an enhanced trust induction. So, as you would expect, we all kind of just local onboarding, meeting key people. And then our second part of that first year was structured training. So we have done a couple of sessions together, so at the start and end of the programme, and then we kind of split. And I'm sure Fern is going to talk a bit more about the FMLM side of the programme. And so there were 2 kind of threads really running, but very much making sure that we were talking to each other and interlinking both those bands of innovation and leadership. So that finished in March. And we're now into year 2 of the programme, which is looking at, as I said previously, putting those skills into practice across 4 transformation projects, which has been great. So we're just in the middle of clinical engagement, and the consultants have been split up into teams of sort of 4 to 5 to complete those. And then the final year of the project will be really kind of self-led by the trust, with support from the Chief Medical Officer, with the look to kind of embedding those skills in the trust, as I said, community practice, and looking at how those skills can be used in other potential transformation and leadership projects, in a sustainable kind of way going forwards. I think that is me. So I'm going to hand now over to talk about the FMLM side of the programme.
Brilliant. Thank you, Claire. And what a great transition with the selfies that we took during the sessions we led. So hi, everyone. Really good to be here. Thank you for joining the webinar. My name is Fanash Sharif. I'm a GP. And having had a variety of leadership positions in the NHS over the years, my last one being of a place-based medical director, I now work as an executive coach and a senior fellow with the Faculty of Medical Leadership and Management. So I worked very closely with the CLEAR team and with a colleague, Jane Cryer, who couldn't be with us this afternoon, to develop the leadership aspect of this program. We delivered a combination of action learning sets, we had coaching sessions, and we had face-to-face workshops, 12 face-to-face workshops, all running over just under a year. And between each session, between each of our face-to-face workshops, we gave participants a gap of about 4 weeks between the modules, so they had time to really understand what they had learned and apply that learning in the places where they worked at the trust. And we're very lucky as well in that we worked with a variety of consultants from a number of specialities. So we started off by using the sort of pillars that FMLM have, and I think Jessamine mentioned them in her talk. So our aim was essentially to start by enabling consultants to understand first who they are and how they operate as leaders. Given the challenges around resilience and burnout in the NHS, our first session, and a very special session, was held on personal resilience, and we brought in a lot of tools, including things like breath work and practical ways in which they could deal with the mental and emotional challenges of leading across the trust. We also used things like DISC psychometrics, so people could understand their communication styles, what motivates them, what stresses them out, how they deal with conflict. And then building that on that foundation of understanding the self, we then empowered participants to understand how they would then use these insights to lead teams. So we used examples, frameworks such as the Lencioni model, talked about things like psychological safety, talked about how individuals or participants would come together and lead through change, which can be very challenging, as I'm sure most of you know. And this then led us onto a series of sessions on how they could then lead through organizations. So culture, workplace culture, was a key theme of our workshops, and that really threaded through to a lot of the other sessions we led. We talked about how participants could understand their stakeholders, how they could manage them, build the really meaningful, purposeful relationships with stakeholders, and how they could combine all of this to really think beyond their organization and work across the system as system leaders. So we had our feedback at the end of every module, and we really used this to fine-tune the next module if needed. And I'll hand over to, I think, Nina and Matteo, who'll probably give you a little bit more insight into some of the things that they took away from the program. But just a few headlines from me before I hand over to them. I think the biggest form of feedback we got was they liked the fact that the session was very practical. We did bring a lot of academic theories into it, But at the end of every module, participants left with a framework that they could use to think about and apply in the field that they were working in. So they had exercises that they could do. They were very clear on the steps that they had to take in order to make meaningful change. And then, of course, the action learning sets were particularly helpful because we used these as an opportunity to really dive deep into any particular challenges that the consultants faced and help them sort of thrash through some of these challenges so that they could continue leading on transformational projects that they were working on. So I think if Matteo, Nina, if you guys are around, it'd be great to get your thoughts on feedback on the program. I think we've got Nina. Maybe I'll hand back to you, Matthew, to coordinate the rest of the
Nina and
conversation.
Matteo still with us? Nina and Matteo still with us?
Yep, I'm here.
Yeah.
Sorry.
Please feel
Yep.
free to give some reflections. That'd be lovely. Thank you, Matteo.
Fantastic. So, and is Nina here as well?
Yes, go on, Matteo.
Wonderful.
Brilliant. Okay, so it was the LBB program was actually the primary reason I applied for my job at BHRUT. I'd worked here as a registrar and it had always been on my radar as somewhere I'd like to come back and work at. But when I saw the LBB job advertised, I sort of thought this is a unique opportunity and one to grab with both hands. And actually, on reflection, I'm glad that I did. I found it a really useful first year of the program, really interesting. And I think from a leadership perspective, as somebody who's sort of gradually built an interest in it over the sort of earlier years of my career as an SHO, but particularly as a registrar, to work in a trust that has given an opportunity not just to expand our leadership skills, but has also invested in us to do that, has been quite a feat from both the trust and also from those involved. And that's probably been one of the biggest things for me taking away from it, was the opportunity and the space to develop my leadership, knowing that I had the backing and the support of both the trust at a CMO and exec level, but also my own department had been extremely supportive in my role within this program. So I think it's an excellent program, but very, very much needs that trust buy-in into it, because a bit like Jessamy and James said at the start, there's a big assumption in the NHS that as you become more senior, you take on a leadership role. You become a lead within a section of your department. You become a CD, a divisional or clinical group director, and then maybe go higher. And there's this kind of assumption that often I find that if you are a consultant, you can lead a team clinically on the shop floor day to day, then you must also be able to lead a team from a operational point of view. And I think that's one of the big things where the NHS often doesn't get it right. But programs like this and input from the FMLM and also CLEAR really have helped to structure and build those skills in us in a way that the traditional kind of 1 or 2 day, often more theoretical leadership courses that you do as a registrar before being thrust into these leadership positions don't necessarily give you. So for me, it's certainly been good to have that trust backing and executive belief in our potential for skills, but then to be given that space within our jobs, within our job plans, to be able to actually have education, self-reflection, and work within a group. Because again, that's the other thing, we often get siloed. I work in obstetrics and gynecology, and I know certainly for us, we can often end up in our own little section of the hospital. You know, you have the maternity ward, the gynae ward, all off in their own, and you don't necessarily interact as you get more senior with others outside of that specialty, except for a referral or on a project. So to have that opportunity to work and learn and grow with a group of consultants was almost like being an F1 back in the doctor's mess again, where you're all rediscovering and learning together and building those networks, which sometimes get a little bit lost, particularly during your busy registrar years. So that's kind of my thoughts on it, but over to you, Nina.
Thank you, Matteo. My name is Nina Gerdes. I'm a consultant nephrologist. And when the program came out, I was at the trust for a year and a bit. And to be honest, I had reached a bit of a trough. I had arrived enthusiastically but my specialty in particular, but like many others, is very much challenged currently because of the financial climate, and that really impacts on our patients. So I saw this opportunity, or the marriage between CLEAR and FMLM. And yeah, I applied to it and I was selected. And I think I am so glad and so grateful for it. You know, like Matteo pointed out, it has so many benefits. And the benefits I see, you know, whilst before I was enthusiastic and motivated to change things for the better, but you know, we have not learned on how to do it. I have actually been part of someone who did a service transformation, but I was not included in it, and I know what that does to people. So it was fantastic to see. Or you know, it's still great with CLEAR to really learn the method. You know, start a project properly, because I think that has the most chance in being successful. And the FMLM bit helped so much to, you know, learn about yourself, learn about others, which enables you to become a lot more resilient and to react better to get people on your side, which, yes, it has been super practical, and probably we're using it every day, part of the project or not. And I think the third really significant point, and that officially the trust doesn't know, is that connection with other specialties. We had this obviously during the program, but also during the action learning sets, and already a few new projects were born, which, yeah, I think it has been fantastic, and I'm really happy to be part of it.
Great. Thank you very much, Nina, and Matteo, for your feedback and your thoughts there. I think, Claire, if you don't mind breezing through the feedback, because we're a bit behind time, but we've heard a good chunk of it, I think, from the participants there, but if you don't mind.
No, I'll absolutely whiz through this. So we collated feedback before and after the start of the year one, teaching on both innovation and leadership. As you can see from the slide, really positive feedback, and also thank you to Nina and Matteo for that lovely feedback as well just then. And again, you can see that it again has strongly influenced people's decision to stay at the trust, but also in terms of improving experience of working at the trust. So again, fantastic, linking back into what we were talking about earlier around kind of staff well-being and that feeling of empowerment and ownership. If we flip to the next slide, we've just got some quotes about what people have gained. So again, people have had that protected time every Wednesday. It's been a fantastic mixed cohort of specialties. And as Nina said, it's things that people are able to put into practice, not just as part of the transformation projects that we're doing, but in that day-to-day kind of learning. So I won't read these out, but so there's some feedback there on the programme. I'll hand back to you, Matt, I think, for the discussion.
Yes, thank you. So we'll bring all the speakers back now. Be prepared to unmute for some questions.
The weird logo. I'm Will Flannery. I'm Deputy Chief Clinical Information Officer at the Royal Berkshire Hospital, and I'm the head of the Health Data Institute. And James, we met at FMLM conference in Manchester when you presented this with one of your data science colleagues. I think what is very important is is that increasingly we need clinical leadership in the data sphere. Because a lot of this will actually fall over if there's not a good relationship with informatics. Because you can state the problem and say, right, we're going to model it, and then we're going to do these inputs, and then we change the model. But you can only do that if the data is there, and if it's actually in a form that you can use. And you can't assume that our data in our EPR and the electronic health record warehouses are actually usable in the majority of cases. So what I would recommend is that those of you who are interested in data, there are ways of becoming clinical leaders in this area so that you can direct this. You can rely on your friendly BI informaticians to a certain extent, but ultimately we need as clinicians to be able to direct this, and also understand that if there are things that we want to do and the data isn't there, how we then go about working with the EPR teams about collecting that data so we can answer the question.
Yeah, great. John, did you want to comment on that? I think that's right.
Yeah, very much so. So Will, I completely agree, and I think it's actually a tricky one because effectively as clinicians or as doctors as well, we've trained in one set of skills, aren't we? And then we have to then learn the leadership skills, which grow throughout our career, and then also, or our lives even, and then also then to learn about data and technology and how it's used and put together. And it's actually they're three quite disparate sets of skills that are required in order to deliver that evidence-based transformation that we know is going to have the impact for our patients. There's no easy answer that I found that's about how you can have one person that necessarily has all the different attributes. But when you have the right team, which has sort of a shared understanding of how to communicate well with people who have the appropriate knowledge of each different technical area, you can then actually get a lot of very good stuff done very quickly. We do within the CLEAR program and within the work in the FMLM try and build some of these skills throughout the course of the programs that we run. But I completely agree with your point, is that it takes a significant period of time within your career to have the full to have all of the skills that are needed. And if you don't engage with IT colleagues early within any of this kind of work, you don't engage well and consistently, you won't be able to deliver half the impact that you want to. Because so much of that capability is so much of that very robust capability is housed within a very busy department within the organisation.
So the wider issue for FLMM is, how do you, as a leader, how do you gain domain expertise to lead, but not domain expertise to be a practitioner? It's a huge challenge. So, for example, if you wanted to lead in data science and not be a data scientist, try and find the course that gives you enough information to lead, but not enough, but doesn't swamp you with so much information, because they're training practitioners. And I'm sure this must be true in legal, must be true in ethics, it must be true in research, it must be true across the board, that getting domain expertise as a leader to lead, in other words, executive domain expertise, if you like, is really quite a challenge. It's one I've managed to personally overcome in data science, and I'm very happy to share my learning about how I learned to lead in data science without being a practitioner. But I'm sure this must be a challenge for leaders across the board as things become more and more technical. It's not just a question of inspiring people to perform better and all these sort of things that come out of the leadership things, but actually to have domain expertise at a leadership level that lets you take your experts and let them excel. But making sure that they deliver patient safety, patient improvement, addressing health inequalities, help with service planning. That takes a clinician to give the constraints to make sure that everybody stays on board on delivering. It is a real challenge. I think I've solved it for myself in domain with domain expertise in data science, but I think it's a challenge across the board.
Yes, yeah, absolutely agree. Thank you very much for that. Now, I'm afraid we are coming to the end, so I'm sorry for those who have their hands up. We'll happily, if we move on to the next slide, we should have our contact details there. So anyone wanting to continue the discussion, we've got some information there that's about to pop up, some contact information there. I'd like to thank everybody involved in the webinar, especially thank you to our speakers for coming and giving up their time. Really appreciated insightful feedback on the programme, insightful thoughts. Quick shout out to all the people who behind the scenes doing the hard work, Namisha, Laura, Luke, to name a few, but thank you for helping set up this webinar. And I think Vanaz mentioned Jane Cryer already, and there was also Lisa Newbold involved in that Leading Beyond Boundaries team, who've delivered a fantastic piece of work. Obviously, this is a challenge that is, raising some passionate points from all of you, and really appreciate that. It's a challenge we think needs to continue to be addressed in all its various forms, and CLEAR and the FMLM as a partnership are going to continue to look at this. If it's a conversation you want to continue, I think we're going to try and flash up the email addresses now. If someone can just click through the slides a bit further. we're happy to
Apologies,
have that
Matt.
discussion.
The text isn't playing on the slide, so
Oh,
if,
okay, no worries.
Laura or colleagues could paste that into the chat, and we've got the email addresses there for people to get in touch with Clear and
Yeah.
FMLM. It's not playing on the slide for some reason.
Okay, no problem. We'll pop it in the chat. But clearly the challenge has been outlined, and it's something that we continue to need to work on as a healthcare community. And yeah, anyone interested, please get in touch. The Leading Beyond Boundaries is one example of how we can do that, but obviously the principles remain the same and the delivery can be different and adjusted to need. We will be emailing out the slides and a recording of this for you tomorrow, if so that hopefully that'll be helpful. But yeah, thank you very much. Appreciate your time.